Welcome, everyone. Thank you for joining today's webinar, Tobacco Prevention and Control in Rural America. My name is Ikra Haji, and I'm part of CADCA's Geographic Health Equity Alliance. CADCA's Geographic Health Equity Alliance, or GHEA for short. We are a CDC-funded national network dedicated to reducing health disparities related to tobacco and cancer. GHEA, in partnership with the National Network of Public Health Institutes and the Maine Public Health Institute at the University of Southern Maine, is very excited to present today's webinar, which will present the findings from the 2019 report, Advancing Tobacco Prevention and Control in Rural America. Next slide, please. Thank you. I'm sure we're all very familiar with Zoom by now, but I'd still like to go over a few housekeeping notes. For this webinar, all participants will be muted by default, and yes, the webinar will be recorded. For general comments, please use the chat box, which you all should see at the bottom. We will have a Q&A portion at the end of this presentation. So for any specific questions for the presenters, please use that specific Q&A box. That's going to help us keep track and organize all of the questions. And also next week, you will get a post-webinar email which will include the recording, the slides, and any resources we'd like to share with you all. There will also be a link for a brief evaluation survey. We kindly ask you to fill out that survey. It's very quick. And letters of attendance will be given upon completion of the evaluation survey. Next slide, please. So I'd like to introduce our presenters, but before I'd like to do that, we would really like to get to know a little more about you all. I'm gonna do a quick poll. Hopefully this works. Launch poll, yes. Hopefully you all are seeing a poll right now. Okay, it looks like people are answering. Great. So we're going to give that a couple seconds. It's how many years have you been working in tobacco prevention? And then in what region of the US are you working on tobacco control and substance misuse prevention? So I'll give that a couple seconds. And while we wait, I'll start the presenters' introductions. So I'd like to start off with Chris Kinnebrew. Chris is a vice president of programs at the National Network of Public Health Institutes. He provides high-level, organization-wide collaborative direction and support to NNPHI's programs, members, and partners. And he collaborates with the senior leadership team to co-create vision, strategy, and support for the overall mission of NNPHI. Chris's multidisciplinary background in social work and public health guides his professional mission, which is to improve public health through building and maintaining partnerships across sectors. Over the past 20 years, he has developed an expertise in nonprofit business operations and a past record of strategic and tactical success with planning and implementing public health projects and initiatives. Chris graduated from Tulane University School of Public Health and Tropical Medicine and Tulane School of Social Work in New Orleans, Louisiana, and Williams College in Williamstown, Massachusetts. Our next presenter is Dr. Erica Ziller. She is an assistant professor of public health and directs the Maine Rural Health Research Center at the University of Southern Maine. She began her career as a social worker in rural Maine, where she quickly realized that many of the challenges facing her clients were exacerbated by health and social policies that were unresponsive to their needs. Since then, she has been committed to policy-informed research aiming at reducing health disparities, particularly rural residents. In 2011, Erica received the Louis Gorin Award for Outstanding Achievement in Rural Healthcare from the National Rural Health Association in recognition of her contributions to rural health policy. Erica grew up in a small town in Maine and obtained her PhD in public policy from the University of Southern Maine in 2012. Last but not least, I'd like to present Martha Elbaum Williamson. For the past 15 years, Martha was a research associate with the Cutler Institute for Health and Social Policy at the Muskie School of Public Service at the University of Southern Maine. This organization is home to the Maine Public Health Institute and the Maine Rural Health Research Center. Martha recently returned to the healthcare team at the U.S. Government Accountability Office, where she is a senior analyst. Her areas of interest include tobacco control, children's health, and telehealth. Ms. Elbaum Williamson earned her master's in public administration from Syracuse University's Maxwell School of Citizenship and Public Affairs, and her undergraduate degree is from Bates College in Lewiston, Maine. Okay, so now I'm going to turn it over to Chris to get us started. And if you could Yep. And Chris, would you like me to end the poll and share the results?
That would be great, Ikra, if you could share the results before I jump in.
Yeah, absolutely. Let's do that. And poll, share results. Hopefully everyone can see the results pop up. Okay, well, it looks like, how many years have you been working in tobacco prevention? Almost 40%, less than 2 years. After that, we have about 30%, 2 to 5 years. With the lowest amount, 19%, 11 plus. And then in what region, which is very interesting, 31% Midwest, 30% South, 18% West, 21% Northeast, and we do have 1% in the US territories. So thank you all for joining us today. Right, thanks, Chris.
Thanks so much, Ikra, for that kind introduction, and pleased to be here, and happy Friday, everyone. So I wanted to just start off by saying, giving some background on how, as a network, NNPHI got involved in this work and how we formed a team to do this great report. So I don't want to spend a lot of time on the background, but I do think it's important for you all to just hear the context, and so I wanted to share it. So we did work on this report through a cooperative agreement with CDC's Office on Smoking and Health. So wanting to acknowledge their support, which we greatly appreciated. And there have been previous reports on this topic, so this isn't the first report to come out, but I do think it's very comprehensive, and we wanted to take a deep dive, not just to look at the data, but also to look at the policies, interventions, and maybe some of the opportunities for advancing in the future. So I wanted to share that context. Next slide, please. So we, as a network of nonprofit public health institutes, typically when we engage in a project, we select the institutes that have either the most expertise or the ones that have already been doing a particular focus area of work. So we have over 40 nonprofit institute members in our network. And we selected our colleagues from Maine because of their dual expertise, not just in tobacco prevention, subject matter expertise, but also rural focus. So you will get to know the team better through their presentation. I just wanted to give that background. Also, we were fortunate to have on our team a consultant from the National Association of Chronic Disease Directors. So I wanted to give an acknowledgement for Paula Clayton, who did help us with some of the reports from the field, and also throughout the process contributed. Next slide, please. Last but not least, I wanted to acknowledge our extensive review committee for this work. I mentioned it was done through a cooperative agreement with the Centers for Disease Control and Prevention. We were fortunate to have a review committee of 15, I believe it's 15, representatives who represent a wide range of expertise, not just in tobacco prevention and control, but also rural topic area expertise. So I wanted to thank that review committee because they helped us with the conceptualization, search strategy, they reviewed drafts, and they also have helped us share the report with the field. Next slide, please. I did want to make a plug for the National Conference on Tobacco or Health. Big fan of CADCA's meetings, but also we have this meeting coming up. It's quite a ways out, but did want to share the save the date. And if you'd like to sign up for the mailing list for it, you can just visit nc2h.org. We are planning on doing the meeting in person. Please stay tuned. Hopefully we'll all be able to meet in person at that time. Last slide, please. And last but not least, I did want to acknowledge my colleague, Phil Wilbur, who's our program manager for tobacco control. Phil joined us just after we started working on this report. I'm so pleased to have him on our team. He's the main staff team member running the content of the National Conference on Tobacco or Health. Phil, thanks for joining today. And with that, I think that's my last slide. Thanks so much, Erica and Martha.
Thank you, Phil. Thanks for launching us and setting the stage for our conversation today. And many thanks also to Ikra for inviting us to be part of this discussion and webinar. We're happy to be here. I would like to again start out by first acknowledging and thanking NNPHI and Chris and his team and leadership for working with us and inviting us to be part of this project, and also to Paula Clayton for her expertise that she provided us with, and of course that amazing team of advisory committee members that Chris described. I'd also like to acknowledge our full project team, and in particular to acknowledge the work of Dr. Jean Talbot, who really led this work that we participated in and wasn't able to be here today. All right, so to start us off, I'd like to talk a little bit about the purpose and our approach to this particular project. So we became involved, as Chris noted, based on our longstanding expertise in rural health. We have been the Maine Rural Health Research Center for well over a quarter century at this point, and I personally have been involved with the rural work for more than 20 years. And we've had a tendency to focus on very large policy issues around healthcare access, but over the past 4 or 5 years have become increasingly involved in projects that are relevant to tobacco prevention and control, and to lung cancer more broadly, and lung cancer screening and prevention. And so our role in this particular project was to provide some really clear, strong background on the rural context for commercial tobacco and prevention, and to do a kind of a global scan of what has been going on over the past decade at the time we were doing this work around tobacco prevention and control activities, with a particular focus on how they have been tailored to work in rural places. And then finally, we offer in the report recommendations for research and practice. Our approach to doing all of this was first to conduct an extremely intense and extensive literature review. We examined hundreds of articles, we categorized them and put together as most comprehensive a picture of the way that tobacco use and tobacco prevention and control play out in rural places and in rural contexts. And we also worked with Paula Clayton from NACDD to come up with some of these case examples for places in the rural US where special, unique work was being done to address rural populations. We, of course, worked intimately with the advisory panel to get their feedback as we developed, as we consolidated our information, reported on it, and started to develop our recommendations. And then finally, we also did some of our own secondary analysis of the National Survey for Drug Use and Health, which I'll be sharing some of the findings from in a few moments here. All right, so our first set of findings really are this background. What is the rural context for tobacco prevention and control? What do we know about the problem of tobacco use overall? And then how might the unique aspects of rural and its context affect the way that we do this work on the ground? And so first, there is ample evidence, pretty incontrovertible evidence that tobacco use is higher in rural places. Rural adults and youth are both more likely than their urban counterparts to smoke cigarettes. At the time we collected our data, vaping was certainly an issue, but national surveys were not quite caught up to the times. So this is something that bears monitoring in the future. And I know data are starting to emerge about the rural urban differences in vaping. But in terms of smokeless tobacco and cigarettes, by far there is a disparity among rural populations. There is variation across regions, and as somebody who has worked in rural health for quite a while, I'm always having to remind myself and others that rural sometimes evokes a very specific image in our minds, but rural populations are actually very heterogeneous, both in terms of their geography, but the people who live in them. So there is a lot of diversity in rural America that we need to be cognizant of, and that plays out obviously on the ground in terms of this work as well. And then many adult subgroups are particularly at risk for tobacco use. And with that in mind, I'll present a little bit of the data that we analyzed for the National Survey of Drug Use and Health from 2015 and 2016. And for the next couple of slides, I'll be presenting data where we're comparing rural and urban rates of smoking for different groups at risk. And as you can see from this slide, there's certainly racial and ethnic variation in smoking and in tobacco use. And in particular, the groups most at risk of smoking in both rural and urban areas, and the rates are higher across the board in rural areas, with the exception of Asian Americans, but non-Hispanic, white adults, and American Indian and Alaskan Native populations are also at extremely high risk. All right, there are also other vulnerable populations that we wanted to drill down to and explore, and those include individuals living in poverty, individuals who are experiencing any sort of mental illness, and then of particular relevance to you, audience, and the work that you're doing, individuals with other substance use disorders or who are misusing substances are also much more likely than any other group to also have use of tobacco as one of their health challenges. Women who are pregnant, veterans, and LGBT, so lesbian, gay, and bisexual adults are some of the populations that we drill down to, and you can see for every single group, those who are living in a rural place are experiencing higher rates of tobacco use than their urban counterparts. We also really want to note that our research indicates that some of what we're seeing on the ground in terms of these differing rates of tobacco use for rural and urban adults can be explained by some of the differences in the sociodemographic characteristics of rural and urban places. So things like lower education and poverty and higher concentrations of populations that are white or that are American Indian, Alaska Native. All of these are sort of risk factors, but also more prevalent in rural places. But we know that the demographic factors only partly explain what's going on. And we recognize that there is a need to explore other aspects of rural, including things like rural infrastructure, rural culture, and the policies that are going on in rural places. So in terms of infrastructure, what we found in the literature is that there are many different challenges to doing tobacco prevention control in rural places. And at the most basic level, that includes things like challenges with the capacity of the healthcare sector and of communities really to have the workforce and the time and the resources to build capacity in this area. We also know that While distinct technologies can provide access to remote tobacco prevention and control resources, these resources are only as good as our ability to access them, and rural places face great challenges with things like broadband and internet access. We also learned through the literature and feel it's very important to again reiterate that there is no single rural culture. So while I'm here telling you some things that we know about rural generally, those of you who are working in rural places, you really are the experts about your community because there is no monolithic rural culture, and there are many different subpopulations within rural. We also know that there are some unique rural norms of tobacco use, and they will vary by region. So, what the context of tobacco is in the life of a Midwesterner is going to be very different than a Northeasterner. We do know that regionally, that nationally, but in particular regions, tobacco goes out of its way to target rural residents. And so we see things like advertisements for smokeless tobacco at state fairs and other things just repeatedly happening that raise the profile of tobacco for rural residents. We know that some aspects of rural culture may make tobacco use a risk factor for them, but rural residents also have a number of very rich cultural assets that can be brought to bear for prevention purposes. And we can talk about that a little bit more in Q&A if that is helpful. And then finally, I want to urge and recognize that there is a vast difference that people doing this work need to be aware of, and I'm sure all of you are, around more sacred and traditional uses of tobacco versus commercial tobacco, which we're really talking about here for American Indian and Alaska Native communities. We know that within the policy context, that there are lower levels of policy protection for both rural and for tribal indigenous populations. There are a number of on-the-ground community-level challenges to strengthening protection, and even some state-level sorts of sovereignty issues that emerge. And of course, tribal sovereignty of indigenous lands is, I would not say a challenge, but it's something that we who are doing tobacco prevention and control need to be mindful of and make sure that we are acting as good partners and not trying to impose ideas that do not fit in the tribal context. And with that, I would love to turn this over to Martha and to let her talk about some of what we learned about the prevention initiatives themselves.
Wonderful. Thank you so much, Erica, for that great introduction to the context for tobacco control and prevention in rural areas. So another major purpose of this report was for us to pull together the evidence on tobacco control interventions in rural America. And we did this part of our work looking at a period from 2008 to 2018. And in the report, we described the results of our search, where the initiatives occurred, what products they targeted, and what outcomes they reported, and what approaches they used. And our search identified a variety of tobacco prevention and control interventions in rural areas, and these fit into 3 buckets, as you see on the slide: promotion of smoke-free air, prevention of initiation, and cessation or treatment. And in some cases, of course, the initiatives that we found were conducted in concert or in coordination with multi-component programs that were part of a comprehensive tobacco control program, such as the type that CDC recommends. Next slide, please. So I'll start with a few key points about the smoke-free air interventions that we identified in the literature. As Erica noted, really there's a strong evidence base that attests to the essential contribution of smoke-free air policies to the improvement of population health outcomes related to smoking. Smoke-free air laws and rules have been shown to decrease indoor air pollution, secondhand smoke exposure, youth smoking initiation, hospital admissions related to cardiovascular events, and asthma, while at the same time, smoke-free air policies have been shown to reduce tobacco consumption and increase cessation rates among tobacco users. Smoke-free air policies are also associated with anti-smoking norms. And with that, we'd like to introduce another poll to you, which I think will be loaded up soon. But I want to tell you about this poll. We'd like to ask you folks what you think about what proportion of smoke-free air interventions were found in states with an ALA, an American Lung Association grade of F. We were curious about, where the smoke-free air interventions existed, and we wanted to see what the distribution was of them in states with really great smoke-free air ratings and those that were less good. And so I guess I'd like to ask you folks what you think about the proportion of smoke-free air interventions that were located in rural areas where the ALA had rated the state a grade of F. And the options that we have here are a tenth, a fifth, 1/3, a half, or 3/4. And I'm not sure where we are in populating it, but perhaps this is a good time to show what you folks are thinking.
Sure. Would you like me to end the poll and share results, Martha?
Yes, thank you.
Okay.
I feel like we need a little music here. Dun, dun, dun. And the results are that you folks agreed with what we found, that 1/3 of the smoke-free air interventions were located in states that had poor smoke-free air policies. And we thought that this finding was really fascinating and that it demonstrates strong state-level policies may indeed be related to rural implementation of smoke-free initiatives, but at the same time, suggesting that some rural communities can make progress even when the state environment is just not conducive to those efforts. And I guess we can go back to the slides, but in the report, we described smoke-free air interventions in rural areas, and we found that they varied in settings and scope. Many of the initiatives focused on affecting change in a particular setting, not covered by comprehensive smoke-free air laws, such as schools or workplaces, tribal lands. Smoke-free air initiatives generally took two forms: interventions aimed at changing policy, and also those aimed at building readiness or capacity to adopt smoke-free laws. And our report includes descriptions of really interesting interventions. There's a great deal of detail in the report about many different types of interventions that achieve smoke-free air outcomes. We describe programs in North Carolina schools, on tribal lands, in Mississippi and Oklahoma, and in Kentucky, among others. And one interesting intervention in Kentucky, just to give you a little bit more flavor for what we were finding, in Kentucky, where state-level smoke-free laws were absent at the time of our review, and local smoke-free ordinances cover only about 1/3 of the population, communities used technical assistance to increase their capacity for smoke-free laws. And the study that we looked at showed that counties that received technical assistance on advocacy skills, on leveraging resources, educating elected officials, and building demand for smoke-free laws, like through education, we're more likely to have implemented smoke-free laws, and those laws covered more of the population. If you like that kind of detail, there's quite a bit more in the report. Next slide, please. So our review of interventions also identified a second bucket of interventions, those aimed at preventing initiation. Most of these were focused on tobacco use. Others included a focus on smokeless tobacco products, e-cigarettes, or had a primary focus on smoking, and one focused on flavored tobacco. And the approaches that we found included policy interventions as well as mass media or counter-marketing campaigns. And so policies that we identified, for example, advertising restrictions or raising the unit price of products and raising the minimum legal sales age, for example, tobacco 21 laws, such as recently passed in Maine, they're among the most effective high-impact interventions for prevention of initiation of tobacco use. We also identified 3 mass media or counter-marketing efforts with multi-state or nationwide reach. The CDC's Tips for Former Smokers campaign that you may have seen, the Food and Drug Administration's Real Cost campaign, that one focused on rural male adolescents at risk for smokeless tobacco use. And we also found an initiative sponsored by the Truth Initiative. And in the report, we highlighted the work of the CDC's Tips from Former Smokers campaign and what it has done to reach rural and tribal communities with things like supplemental local media buys in rural areas with high smoking prevalence, and also geofencing projects that deliver campaign messages to cell phones within a particular geographic radius for a specified amount of time. But one important point, and that is that a large proportion of the prevention programs that we identified use tailoring and incorporating culturally specific themes in counter-marketing campaigns and working with members that target communities to generate, that work with the target communities to generate content. But also we wanted to share our finding that peer-reviewed studies suggest that mass media campaigns following CDC's best practices guidelines can achieve positive results even without, in the absence of significant tailoring. So I think that's an important finding because it implies that rural communities can use off-the-shelf, low-cost or no-cost mass media campaigns that already exist and for which there is some evidence. Next slide, please. So on to the third bucket of interventions that we located in the literature. And that our review located over 70 tobacco treatment or cessation interventions implemented within rural populations. Rural cessation programs in our review used a range of modalities. Some focused on promoting cessation through policy, once again, policy changes such as increased taxes on products, restrictions on smoking in particular settings. These show strong associations with cessation and prevalence of use. We also, the prevention or the cessation initiatives also used counter-marketing and media campaigns, and these are well-supported, highly effective techniques for increasing quit attempts and successful tobacco cessation. But the majority of initiatives that we identified included treatment involving behavioral counseling. These programs, these treatment programs, frequently followed best practice by offering pharmacotherapy in conjunction with counseling. Interventions that we identified were delivered by healthcare professionals, pharmacists, quitline staff, as well as lay health advisors or health educators. And we identified rural cessation programs both inside and outside of traditional settings. Now, many of the programs were designed to address infrastructure challenges the type that Erica described in her presentation. Infrastructure limitations that may contribute to tobacco prevention and control context in rural areas. Programs incorporated strategies, though, to overcome those infrastructure challenges, such as workforce shortages or needing to travel to distant areas to obtain services. And so we thought that was a pretty interesting, response to the tobacco control context in rural that was overcome by particular design in the cessation programs that we encountered. Why don't we go to the next slide? So in our report in Advancing Tobacco Prevention and Control in Rural America, we also provide a number of recommendations. We include one group of recommendations to federal and state agencies. And the first of these is to allocate resources on the basis of epidemiological burden as well as population impact, so that rural areas with higher prevalence are not systematically disadvantaged in funding formulas. Another recommendation is to supporting service provision by non-physicians and lay health advisors through ensuring that state licensing regulations and Medicaid reimbursement policies will accommodate such practices, again, to address the infrastructure limitations that some rural areas have. And also, we recommend ensuring that rural stakeholders have an opportunity to provide input and influence to federal and state tobacco control policy. And here again, we want to go to our next poll. So in our report, we recommend that federal and state policy be informed by rural stakeholders from local health departments, hospitals, and public health departments. And we'd like to know from you folks, based on your knowledge or experience, how often do rural stakeholders have an opportunity to inform state tobacco control policy? And the response options are almost always, often, sometimes, seldom, or never. And feel free to answer just thinking about a rural community near you or with whom you've worked if you don't live in a rural area.
We are almost at 50% response, so we can just give it a couple more seconds, Martha.
All right, thank you.
Okay, would you like me to end the poll?
Yes, that would be great. Thank you so much. Okay, so most of the results are for sometimes and seldom. So not a strong endorsement for a real feeling that stakeholders are able to affect policy in states. So maybe we should file this finding, file this away. And I hope that perhaps during our questions and answers, we can discuss this. There may be some ideas that folks in the audience have for what can be done to affect policy at the state level, because really where policy seems to be a very important way to make a difference. I see in the comment box, we often inform, but they might not get it. So even when you do have a chance to inform, state level policy isn't affected. All right. In the interest of time, let's move on to the next slide. So the second bucket of recommendations that we had in the report, and there are, again, many more, so we hope you pick up the report. We had recommendations for local stakeholders, tribes, and communities. And the first, I can tell you in 3 words: policy, policy, policy. Investments in policy are clearly warranted given their effectiveness at achieving not only smoke-free air ends, but also prevention and cessation or treatment aims of tobacco control policy, of tobacco control. So we also have a recommendation in the report for rural health systems. Rural health systems can implement evidence-based, system-wide tobacco prevention and control plans. For example, they can adopt 100% tobacco-free campus policies. They can train staff in best practices in tobacco cessation. They can engage lay health advisors in service provision. And they can implement, for example, quality improvement projects using their electronic health records to monitor progress towards tobacco-related population health goals. And another recommendation that we include in the report is that local health departments and others concerned with rural tobacco control efforts should engage parents. Parents can advocate effectively for measures to protect their children from secondhand smoke and restrict youth access to tobacco. Next slide, please. So in preparing this report, our team had many different ideas for future research. It was really actually one of the most enticing parts of this project was to think a little bit about what's next. What ought we look, what should researchers engage in? And two of them are to clarify perspectives on rural tobacco control, including local health department challenges, assets, and needs, so that knowledge can be applied to future tobacco control efforts. And a second area for future research that we thought would be helpful that would advance tobacco control is to improve the evidence base for culturally informed initiatives through community-based participatory research and evaluation. Let's go to the next slide. So that, in a nutshell, is an introduction to our report, Advancing Tobacco Prevention and Control in Rural America. We've provided a link to the full report and the executive summary. We want to thank GHEA and CADCA for sponsoring the webinar, and NNPHI and CDC for their support, and our audience for participating in the polls. And we would like to then go to the next slide so that we can have a good discussion and respond to questions and comments. And actually, go ahead and advance to the next slide.
So thank you so much, Martha. We have a couple of questions. Chris, do you wanna ask the questions that we have? Would you like to do that?
I'd be pleased to. Can you hear me all right?
Yes, thank you.
Great. So the first question we received was from Lynn Barron. Is there any indication with the SUD group if tobacco was the first drug used? And I'll just say I can't recall from the National Survey on Drug Use and Health data if that's specifically there. I know that's a pretty detailed question, but I wanted to share it.
We definitely didn't look at that, but I'm thinking about the survey questions, and they certainly, for each substance, ask sort of the age of first use. And I think it could be possible to go through and kind of sequentially do some reconstruction of that. That's a really interesting question. I suspect somebody in the world has, done that research more broadly, but I don't know if it's been done for rural populations. So I'm going to add that to that enticing list that Martha was just talking about for something that maybe we should consider looking at. Thanks. Great question.
Thanks so much, Erica, for answering that one. Next question is from Guyan, and excuse me if I get the pronunciation wrong, Chambliss. Is there any data on the differences of nicotine use between sacred traditional uses versus commercial? Once again, very specific question. I can't recall that. I know we had a lot of discussion and input and through our advisory committee, review committee, and others on the nuances of the language, but just put the question out there.
My understanding is that the National Survey of Drug Use and Health tries to make that distinction. I don't know how well it works, and I know we didn't have any data except what we had read in the literature and what we garnered from the advisory committee about. I mean, we understood that obviously there are extremely different purposes and intents for these. We don't have quantitative measures from the work that we did.
Thank you.
But something we are trying to be mindful of, certainly, as we talk and write.
Great. And the next question I'm actually going to read out, but I may ask for the questioners to see if they can respond with a little bit more clarification. So the next one's from Stephen Updike. It's about rural cultural assets, and don't the negative health outcomes outweigh any perceived benefit? My quick response, and I'll of course open it to Erica and Martha and others, was that we wanted to make sure in doing the report that we were acknowledging the cultural assets that could be valuable in advancing tobacco prevention and control, as opposed to thinking of tobacco use as a cultural asset. But I don't know if you, Stephen, if you want to put any clarification around your question there, but I just wanted to share that answer and see if Erica and Martha.
Yeah. And I apologize. It's possible that when I was discussing that point that I might not have been clear, but as Chris said, that's exactly what the intent of that point is, that there are things about rural culture that may promote health behaviors that are more risky, but there are also things that we can leverage. So the first thing that comes to mind is in Vermont and Virginia, they launched this initiative called the Down and Dirty campaign, which really is aimed at addressing youth smoking through the lens of outdoor activities. So they really, because a lot of rural is about four-wheeling or hunting or doing other snowmobiling, a lot of those outdoor activities, to link doing those activities to being smoke-free is a way to leverage that cultural identity of rural youth and uplift it, and at the same time be providing that anti-tobacco messaging at the same time. So that's kind of an example of what we mean by using the cultural assets as leverage. And I don't know, Martha, if you had anything you wanted to add.
Oh, just another example would be the close-knit nature of rural communities and willingness to come to mutual aid that can also be leveraged in designing programs.
Thanks so much. Okay, I'll move on, and I'm doing these not quite in the order that they're in the Q&A, but I'm gonna give this next one because I think it's fairly specific. So we had an anonymous question come in about what are some examples of advertising restrictions. Our small town tends to be wary of anything that limits economic development. And I'll just share, because this was one of the images in the report from one of our stories from the field. It was specifically retail advertising, storefront advertising. Of course, there are many forms of advertising restrictions. Erica and Martha, do you want to share any thoughts on that one?
Well, I just would like to give a little bit more detail, because in the report, we've got this photograph that shows a community that adopted advertising restrictions, and it shows a picture of a convenience store before and after the policy went into place. And then, before the policy went into place, you saw advertising for, cigarettes and alcohol, and they covered all the window space there. And then afterwards, there was just much tidier, all that advertising was gone. So there's a photograph, I think, of the before and after in the report.
Thanks so much. And two, I know this is, maybe more along the lines of promotions than advertising, but I think there was also some mention of rodeo sponsorships, but I may be misremembering, so apologies if that's not in the report. But I think that was one of the, also anyway, but once again, it's a very comprehensive report, so I have to look it up. So there was, thank you, Sally Petty, for this question. What are your recommendations for coalition infrastructure in rural areas? Any suggestions on how to track and measure growth in that area? I'll put that out to the panelists. I may have a thought, but I'm still processing.
Certainly, I would say, who you bring to the table and build for your coalition is one of those things that, again, is kind of dependent on your community. You obviously want people who are seen as respected decision makers, either are viewed that way, or people who actually have some authority and ability to make a difference. So I think it's one of our findings, which is probably true universally and not just rural, but one of the messages that does resonate with rural residents is protecting children. So having schools engaged and having, if you can get your local chamber of commerce to the table, maybe you'll get some pushback, but maybe there are issues where you can find common ground. I know that one of the stories that I had heard was getting the Little League coaches kind of on board to not chew or smoke while they were coaching, just trying to make that baby step sort of thing. So I can talk about that just sort of broadly. And then I haven't done a lot of work about actually measuring the strength of community coalitions. I know there's some work about that in the literature, and maybe that's where Chris was going, or if Martha wants to jump in.
This is where my memory is not serving me, but I do know that there was at least one study that we do describe in the report that did measure the strength of tobacco control efforts. I think it took place in Kentucky, and that's all that I can summon right now. There we go. Oh no, I thought that was a response in the chat box. But I think I can get back to you about that, or you can take a peek at the report, and I think it will be easy to find that intervention.
Yeah, I wasn't kidding when I said we read many, many hundreds of articles. So we can speak to the broad themes much more quickly than some of the minute details.
Great. Well, I know we've got some great questions coming in. There was a question from Mary Karen. In your research, were there any particular states in particular that stood out as having particularly well implemented rural tobacco prevention efforts? I'd just like to share my own personal opinion. And, I know Maine stood out. I remember that. And, that was not, when we selected working with the team from Maine, that was not one of the factors necessarily, but I just want to give a shout out to Maine. What are your thoughts, Erica and Martha?
Well, I just want to build on what you said about Maine, in part because Maine is very interesting because it is a very, very rural state. So it really demonstrates that rurality can go hand in hand with strong tobacco control policies and programs.
Great. And there's a question from Gayani Shamblis about what about the issue of compliance of smoke-free air policies in our country, in our county. We have found enforcement to be non-existent. I'll share that with Martha and Erica.
Yeah, so I would say this is, I'll just give a thought and then defer to others, but have been doing a lot of reading on sort of rural health ethics, and one of these tensions that keeps emerging is the autonomy of individuals and individual communities, and I know that it kind of goes the other way as well. So we have states with you know, that have strong centralized legislation about tobacco control, and in fact preempt the ability of communities to do anything. So it's more of a hands-off approach at the state level. If you do it in the reverse, where a state may implement policies, but there are pockets of rural communities where there is a lot more resistance, there isn't buy-in, then it creates those dynamics. And I think it just speaks to the importance of doing the grassroots work and building the coalitions to bring the communities along, because that enforcement does have to be done at a local level. And I don't know if Martha or Chris had other thoughts.
Thank you.
I don't. I did want to relay another question from Andrew Derry. How are quit lines utilized in the rural setting, and are there recommendations on how to promote them or another option to use? I know quit lines are, you know, if you did a control F in the report under quit lines, it would come up numerous times. And I do remember too, there was a story from the field, I want to say it was from Deschutes County or Deschutes, about that specifically talked about I think, you know, some sorts of integration with the quit lines. But Eric or Martha, do you recall anything more specifically about quit lines and recommendations? And if not, I understand.
Yeah, I'm sitting here and I'm thinking, nope, that was some of what I'm thinking about are some of the other tech, like I know that one of the groups was looking at working with indigenous populations and using text messaging and things like that, but that's a different, I'm getting a couple of examples muddled together.
Yeah, I'm not, this isn't exactly responsive to the question, but I think that one of the things that I recall strongly from the literature was that that mass media campaigns can drive traffic effectively to quit lines. And so using those in tandem can really be effective.
Mm.
Great, and I'll just relay another one of the questions from Tracy Pohl. Are youth, young people involved with this work in partnerships with your efforts? You know, I'll just share in terms of the National Conference on Tobacco Health, we've been very successful engaging with the Campaign for Tobacco-Free Kids and have kind of tried to build out a youth engagement aspect of that. With regards to this report, I mean, I don't recall that we had Campaign for Tobacco-Free Kids or a youth-focused organization on the review committee. But I do remember there were numerous, you know, examples, and, you know, Erica and Martha, I'm sure, I know this came up in the literature review, but just wanted to see if you all had any reflections on that question in terms of youth engagement.
We do describe a few programs.
Go ahead.
Oh, thanks. And then I'll we do describe some programs that began with youth engagement and were actually one started with just a little, I think it was in Oklahoma, but I could be wrong. So look at the report for sure, where there was a program that just started with one youth conference, and it ended up, you know, resulting in tobacco or smoke-free air policies being adopted much more broadly in community after community after community, and then eventually to statewide policy. And I don't think it was Oklahoma. I think it was North Carolina. Erica, were you, did you have something that you wanted to say before I?
Nope, you got it.
Okay.
Great, well, I know we're approaching the end time of the scheduled webinar. I did want to just say, I can keep going for a few minutes, but Erica and Martha just wanted to respect your timelines, but there are obviously some more questions.
I do have another commitment, but I can hang on for another minute or two.
Great. Why don't we do one more question? And well, I guess I'll kind of condense two questions because I think this was about smoke-free housing and policy questions related. And there was one specific question about, is there something available to give to apartment managers about, this one was specific to vaping harm, both first and secondhand, but I think the other one that was just about kind of a more general question about looking at policies related to housing and smoking. Do you all have any thoughts particularly on that in the rural context?
And in the report, we describe one intervention. Again, I can't remember the state right now, but it was focused on housing units. And in that study, I think that one of the major findings was that actually information about some of the concerns that people who have, multi-unit housing might have, like, for example, addressing concerns that they might lose renters, and and also providing information about cost savings by not having, but through smoke-free air rules in the housing units were effective.
The only thing I would add in terms of, smoke-free housing of people's individual homes and units is an area that's, I would think, would have the strongest pushback from rural communities and be the most difficult to implement and to pass and implement, just because if you, and again, I'm painting a broad brush over rural with some averages, but if you look at national surveys, obviously we have anecdotes of this, but if you look at national surveys, there is a very strong thread of independence and personal individual autonomy in things like people's homes and people's cars that is much more tangible in rural communities than in urban communities. And there's definitely lots of polling data about that. So important work to do. I think this is an area where education before policy is going to be really, really important.
Mm-hmm.
Great, Chris, we're good to go?
I think we're good to go. Thank you so much for the great question.
Yes, thank you. Thank you everyone for all of the questions you all submitted. Thank you presenters for answering as many as you could, really appreciate it. So as we conclude the webinar, again, a huge thank you to Chris, Erica, and Martha for presenting your work and for your commitment and dedication to advancing tobacco control and prevention in rural America. And a big thank you to the webinar participants. Thank you so much for your comments, your questions, insights. We really appreciate your participation. And as I mentioned, the post-webinar email will be sent out early next week. It's going to have the recording, the slides, and any resources we want to share, and of course, the evaluation survey. So thank you again, and we hope you all have a wonderful rest of your day.